Hi, welcome back. My name is Edward Halperin. I am the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of Touro University. And this is 90 Minutes, the medical magazine of the web. We started out these programs teaching everyone all about the COVID-19 pandemic. And now we've expanded our focus to talk with you about major issues facing healthcare. Our program is geared both to healthcare practitioners and the general public, and we strive with each broadcast to address topics that are foremost in the news. We have, as always, a cast of stars for you to present. We're going to start with Dr. Anitha Srinivasan. Dr. Srinivasan is the Chief Medical Officer at Metropolitan Hospital Medical Center in Manhattan, one of the teaching hospitals of New York Medical College. She is a breast surgeon. And I've asked her to talk with us today about the changing landscape of mammography for breast cancer screening. Women are driven crazy by this. Every time you look in the newspaper, it seems like there's a new set of recommendations. Should you get them when you're over 40 or 45 or 50? Do you need them every year, every other year? Who's the definition of high risk? Well, there have been some new guidelines issued for screening mammography, and I've asked Dr. Srinivasan to walk us through them and teach us what we need to know about screening mammography. Our next topic is going to the other end of the body. We are going to have the Dean of the New York College of Podiatric Medicine, Dr. Michael Trepal, with us. And he's going to teach us all about a very common but not too pleasant topic to talk about, toenail fungus. I've titled his talk, "Dad, Your Toenails Are Disgusting. Are you going to do something about them?" Well, there are lots of people who've been to their doctor who get told the treatment often doesn't work, it takes a long time, it's not bothering you, don't bother it. Well, there's some new therapies on the market. I thought we should have Dr. Trepal teach us about this common problem and what one should do about dad's disgusting toenails. Next up, among the most common drugs that people take are drugs for their heartburn. Proton pump inhibitors, omeprazole, and drugs of that class. But there have been some reports asserting that these drugs increase the risk of dementia. That's a serious matter for a drug which is taken that commonly. I wouldn't be surprised if many of you listening to us this afternoon are taking an over-the-counter version of one of these drugs. So I've invited the Chief of Gastroenterology at Westchester Medical Center, New York Medical College, Dr. Edward Lebovics, to talk with us in a panel discussion with Dr. Etienne, a neurologist who practices at Good Samaritan Hospital in Rockland County, New York. And we're going to have a little chat about one doctor saying you ought to take a proton pump inhibitor for your gastric reflux and your heartburn, and someone else saying, well, they might increase the risk of dementia. Should you take the drugs or not? Next up, after our panel discussion, is we're going to hear from the chair of the Department of Family Medicine of New York Medical College, Dr. Lori Solomon. I've asked Dr. Solomon to talk about a common problem, which is the doctors always ask me about my family medical history. Does your family have a history of this disease or that disease? What do you people actually do with that information? And how compulsive should a person be about keeping records of their family history? Do I really need a photostatic copy of my mother's medical records in case anybody asks me about them 20 years from now? What's appropriate for a patient to hold on to for family medical records, and what should doctors be asking about the family history? This is also a common problem which I felt deserved our attention. Now, after our speakers are all done, it'll be time for your questions and their answers. So you go right ahead and type your questions in the question and answer box on the computer screen, and we'll get to as many of them as possible during the Q&A portion of our program. For those of you looking for continuing medical education credit, CME credit, you will see me appear periodically during today's webinar to give you step-by-step instructions of how to get your CME credit. Thanks for joining us for our 26th webinar. Welcome back, and let's get started with our program.
Hello, my name is Dr. Anitha Srinivasan. I am a breast surgeon. I am also the Associate Professor of Surgery for New York Medical College at Metropolitan Hospital for over 20 years now. I would like to discuss the topic of breast cancer, some of the screening perspectives. Why have we chosen this topic is because there was a recent very significant change in the recommendations for the US task force to change again its breast cancer screening recommendations in terms of the age of the patients. Next slide. I have no conflicts of business interests to report for this presentation. Next slide. No discussion about screening for risk of breast cancer is complete without understanding the patient as a whole. The way we have changed our thinking in cancer screening is that we look at a holistic approach of each patient and believe that their cancer risk is going to be different from the next patient. So we don't mass group people into populations anymore, and we try our best to tease out the differences. That is a major change in thinking in cancer screening these days. And a lot of that change is attributed to creating risk models. Risk models are not anything new. We've always had historically the Gale model, which a lot of people would know in breast cancer. The newer models are the Klaus, the Couch model, and now you have these online risk calculators, which anybody can put in criteria and determine if their average risk of cancer, like a general population, or they are at an altered risk of cancer or a higher risk of cancer. Next slide. Determining breast cancer risk is done by various methods. Personal history of breast cancer. Yes, somebody who has a breast cancer is going to have an increased risk for a second cancer, which means your breast has already shown that it has a tendency to cause abnormality. We haven't quite understood why, but we do know that it has a tendency to do so, likely that you might have a second cancer. The bigger one and the huge change is the genetic imprint that has had with cancer screening. The genetic screenings have become so advanced these days that it's kind of incomplete to tell a patient that they are at risk, normal risk, or a higher risk without actually assessing their genetic risk qualities, or at least a detailed family history. What do we look for in these family histories? We look for various risk factors, including the degrees of relatives, number of relatives, age at cancer in the family. Usually the younger the relative is affected with cancer, the higher the chance that there may be something genetic or hereditary in the family. Next slide. But that alone is not your risk factor for breast cancer. It's the increasing age, the female gender, the family history is a big part, nulliparity versus multiparity. The race, ethnicity is a huge part. Why do I say race, ethnicity? Because now the reason why the US task force has changed their recommendation is they're finding that usually compared to Caucasian patients, African-American patients do 40% worse. They may not have high an incidence of cancer, but they are worse outcomes, which means the cancers are more aggressive. We are seeing them in younger patients. So this brings me to my next slide, which is the NCCN guidelines actually tells you. The NCCN is the national guidelines that we follow in general for cancer pathways and guidelines. In those cases, what happens is they tell you very clearly when you have to test a patient for a genetic abnormality. So we use this when we see a patient. Next slide. And then we put all the factors together and determining whether the patient's at a high risk or not. Then you give a personalized recommendation for screening age in this patient. Next slide. Which then brings us to what is the screening modality we have. Mammograms have been in existence for a long time, and we have excellent data on their benefits of early detection. It was very controversial in the 80s and 90s about radiation exposure. The risk of radiation-induced cancer in the current mammogram exposure is minimal. We will talk about it. And it's now the benefit of identifying a cancer early is so much better. Why and how did that happen? Because we have a universal language for mammograms, which is a BIRAD, which is what you see, a reporting system where I can carry this report anywhere in the world and people will know whether they have an abnormality or not, and whether it's an actionable, meaning should I biopsy this area or not. Now the question becomes, when do I start doing a mammogram on patients? We know that the mammogram is a good modality. It is a universal modality, and like any screening test, it should be easily interpretable, which it is. However, what age do I start has always been controversial. The American Cancer Society has changed its recommendations every so often, the last one being October 2015 to present. And they say start talking about it at 40 years. Now, the US task force, which was largely recommending the same recommendation as the Europeans, 50 and every other year, suddenly changed it to 40 and every other year. Now, what do we do and why did we do this? They found that as the world evolves into more borderless and interracial mingling, we can't generally say this is your risk prediction. Like I explained earlier, African Americans have a higher risk of a bad outcome and a younger age of presentation. But you're not going to have people in those compartments, especially when you're talking about something like a New York City or the US, which has so much intermingling, immigration, and mixed populations. I'm especially fortunate to work in a population that's very urban. I work for a safety net hospital. I've always believed that screening should be personalized to the population that you serve. The population that I serve is extremely diverse. And I do see patients who are young, who are in their 40s, who constantly have breast cancer. Nowadays, we are also seeing 30s, but because of the fact that the mammogram in a younger breast and an active lactating breast or an active glandular breast shows density or dense breast, and it's less, accurate, we don't recommend it on a younger age group. However, if at 40 you are capable of getting screened, then you should have the conversation with your doctor. Whether it's every other year or every year will be based on the population that your clinic is seeing, as well as your doctor thinks it's essential. There is a lot of controversy, not necessarily any more confusing than any other cancer screening. But to me, as a cancer surgeon, it's very clear. You have to personalize your screening recommendation to the population that you see. You also want to personalize your screening recommendation to your patient based on their genetic risk, whether they are a general population risk or an altered population risk. So these two together in your head should give you the answer, what do you do with your patient that presents to your practice? My recommendation is at 40, definitely have the conversation. I recommend 40 and every year because younger patients with breast cancer present with rapidly growing breast cancers waiting 2 years is not ideal. Now, if I talk to a family physician, they are seeing healthy patients. So the American College of Physicians would usually recommend every other year. They may recommend 50 years in some other part of the country as the starting age. In this part of the country where you're seeing multiracial and ethnic diversity, then I would say I would rather err on the younger age of 40, now that the task force has also come up with a B recommendation for it, and have that discussion with your patient. Now, next slide. If your patient is worried about their screening and what does the mammogram bring to them and whether it exposes them to radiation without the benefit, definitely there's enough evidence to show that mammography has reduced morbidity and mortality in breast cancer. We've come a long way. We want to diagnose stage 0, which is DCIS breast cancers, which are predominantly not palpable, only radiologically visible cancers. We want to diagnose more and more people at that stage. That's why we recommend the mammogram early, and we recommend it yearly. Next slide. So if the patient still asks you, what is my dose exposure from a mammogram? This is a classic mammogram, assuming they're not doing a tomosynthesis, they're not doing a fast mammogram, which technology has really evolved so much better. But even using the classic mammography, the risk of radiation is pretty low. It's, as the slide says, the total risk of cancer is about 44 per million. And even that, we are finding more and more happens in patients who have some form of genetic fragility syndromes. So your average, strong, young patient who's 40 plus, who's looking at cancer risk and is anxious, should get an opportunity to get screened with an annual mammogram. That would be my recommendation. And I'm open to any questions. I thank you for the opportunity to discuss this. Thank you very much.
Hello again, this is your host, Dr. Edward Halperin, to give you instructions as to how to get your CME credit for those of you who want your continuing medical education credit. You have to record your attendance, so you either whip out your cell phone and send a text message to 828-295-1144 and type the code 64VOID, all in capitals. Type that into the message, hit send, and you'll get instructions back as to how to fill out your quality assurance questionnaire for your satisfaction with today's program and how to download your certificate for your CME credit. Your other choice is to use your computer, laptop, or your cell phone and scan the QR code, that sort of checkerboard looking device in the right-hand corner. You scan that and it will automatically take you to the website where you can go ahead and fill out the satisfaction questionnaire and get your CME credit. However you decide to do it, go ahead and do it, because the code's going to expire on Thursday, July 6th at 12:30. It'll stop working after that point. So may I suggest get out a pencil and paper and write this information down, or you take a screenshot, or you take a photograph of your screen with your cell phone. Go ahead and do it so you can be sure to get your CME credit. Now, as I always say, if you want to ask a question of any of our panelists, go ahead and type your question in the question and answer box on your computer screen, and we'll get to as many of them as possible during the question and answer portion of our program. And let's continue with our program.
Good day, my name is Dr. Mike Trepal, Dean at the New York College of Podiatric Medicine, and I'm here to address the topic of Dad, your toenails are disgusting. For this presentation, I have no disclosures that are relevant to make, and let's get going on what onychomycosis is. It is a fungal infection of the toenails and or the fingernails and accounts for close to half of nail abnormalities, typically caused by a dermatophyte fungus. Can in some cases be Candida or non-dermatophyte moles, but 90% of the time it's going to be a dermatophyte. Dermatophytes are also the cause of garden variety tinea pedis, and it is not uncommon, or in fact is more the rule, to see a combination of tinea pedis and onychomycosis. Frequently the tinea pedis will be resolved by over-the-counter or prescribed medications, leaving the onychomycotic nails, which are much more difficult to treat. The problem here is that the fungus gets underneath the nail plate, either by coming in proximally with a proximal nail fold, the eponychium, or distally under the distal nail fold, the hyponychium. There are other conditions which can simulate or look similar to onychomycosis, and they need to be ruled out, particularly before starting a prolonged therapy for onychomycosis. One thing to be wary about is pigmented nails. Sometimes the non-dermatophyte moles can come with pigment, and you have to make sure that we're not dealing with a subungual or acral lentiginous melanoma, which obviously has much more severe ramifications than a mycotic toenail. To diagnose it, there are several ways to do it. The classic way was to take a specimen and heat it in potassium hydroxide, looking for fungi. This is a little bit labor intensive for an office practice and not frequently done. The most common is to take a specimen, send it out to a laboratory to do a FAES stain, which very nicely will identify the hyphae. If you're in need of getting speciation because of resistance to treatment, then a nail culture, or sending the specimen out for a PCR analysis. And again, that will give you speciation in cases where you may think that necessary. Why should we treat onychomycosis? Well, number one, it creates a cosmetic complaint. These nails can be quite painful. The thicker they are, it's like putting a rock on the tip of the toe. They can spread the dermatophytes of the fungus to other areas of the foot. And to avoid complications like ulcerations or cellulitis, particularly in patients with immunocompromised status, neuropathy, or impaired circulation. Here's an example of a diabetic with impaired circulation, ended up having cellulitis. That went on to gangrene. Another case of severe onychomycotic dystrophic toenails in a diabetic with neuropathy and impaired circulation. That was the proximate cause of being a transmetatarsal amputation. Treatment that we have is good old garden variety debridement. These usually, particularly on the thick nails, need to be done professionally because of the difficulty in debriding such a thick nail. A nail clipper, a strong nail clipper to cut through the thick nail plate, a roto burr or an electric burr coupled with an appropriate vacuum system so that you do not aerosol the nail fragments. Or in severe cases, sometimes patients will opt for avulsion of the nail with or without a matrixectomy to prevent nail regrowth. You can topically debride with chemicals, most commonly with urea. Urea is a safe and effective treatment that's keratolytic in nature. Patients can apply it every day. It'll soften the nail and make it easier for either self-debridement or professional debridement. In terms of the antifungals, which are commonly used, these all interfere with the metabolic pathway of converting squalene to gastrol, which is an important component of the cell membrane of dermatophytes. The two main classes are the allylamines or the azoles. They act in different pathways or different places in the pathway, with the allylamines tending to be more fungicidal and the azoles more fungistatic. Therefore, the allylamines tend to be preferable to it. The role of topical therapy would be for treatment of mild to moderate or treatment of recurrence after oral, or in patients where oral is contraindicated, refused, or not tolerated, or of course in combination. The topical antifungals are applied via a brush daily to it. General course of therapy is 48 weeks. The more common ones that are available are cyclopirox, tavaborol, or efinaconazole. The latter two are quite expensive, frequently non-preferred on the formulary, and end up with several $100 co-payments to the patient. The prior two are more readily available and generically available as well. The cure rates on the topical are not great. When we're looking at cure rate, we're looking at mycological cure, which means that you cannot identify a dermatophyte, and a complete cure deals with the clinical appearance of the nail, that the nail has a normal appearance. You can see they are quite low with the topical. So while they're better than nothing and better than a sham or a placebo therapy, they're still not where we would like to see them, particularly in cases of severe therapy. That leaves us with the oral. The main classes of oral would be griseofulvin, itraconazole, and terbinafine. Terbinafine being the allylamine is now considered the more commonly used, and if you will, for lack of a better term, the gold standard of utilizing it. It has very few drug interactions, and it can be safely used in most patients. The notable exception would be obviously someone allergic to it or someone with pre-existing hepatic disease. Even these, you can see that the MICs are not fabulous on this. The best is terbinafine, which again, why it is the most commonly used oral medication for it. The mycologic and the clinical cures on these are modest. It's the best we have in our toolbox. Most patients will see some degree of improvement, but rare are you going to see someone that has a complete clinical cure utilizing these. Using the oral medications prior to initiating treatment, it is standard to get a baseline lab testing to make sure to identify that indeed you have a dermatophyte that's in the nail. If you choose to do a culture or a PCR, you can get speciation, but more often than not, these are efficacious 90 to 95% of the times because you're dealing with a dermatophyte. You want to get a pre-existing liver function test to make sure that you have no undiagnosed hepatic disease. And the daily dosing for onychomycosis of the toenail is 250 milligram pill once a day for 12 weeks or 3 months. Clinically apparent liver injury from terbinafine, it occurs rarely. It's estimated at about 1 in 50 to 120,000 prescriptions. Although there are case reports, it really has proved to be a fairly safe medication, and serial monitoring of liver profile in otherwise healthy patients without showing any clinical signs of hepatic interaction is not indicated anymore. Other therapy that is utilized is laser therapy. Unfortunately, while laser therapy had great promise 10, 15 years ago, with every podiatrist and dermatologist getting a unit, unfortunately, the end results with laser therapy has not proved to be as efficacious. And I think the utilization of it is much less than it was in the past, and really the outcomes are not much better or no better than utilizing the pharmacologic modalities that we have. There are home remedies which are available. The internet is replete with it, of all kinds of snake oil, and the more common things, Vicks Vapor Rub or tea tree oils. You'll anywhere from eye of newt and pickle juice to use on here. Unfortunately, there is no really true good outcome studies that show these wife tails are really efficacious, and they're not going to cause any harm, but really don't go to the cure of the condition. Other things that we need to do is reinforce to the patient good foot hygiene, not sharing nail clippers with anyone else so that there is no cross-contamination occurring, wearing shoes that fit well to avoid nail trauma. Don't use antifungal sprays or powders in the shoe to reduce cross-contamination. Be careful about going barefoot in public facilities. Throw away old moldy or shoes, and make sure instruments are sterilized before having any manicure or pedicure. So that is the lowdown on onychomycosis. It is a common problem, and we can do something to help it, but unfortunately, complete cures are few and far between in today's day and age. Thank you very much for your time, and it's been a pleasure here to briefly chat with you on this topic. Have a great day.
Hello again, this is your host, Dr. Edward Halperin, and I'm here to moderate our panel discussion about a very common concern right now for many people and their healthcare providers. What are you going to do about the management of your gastric reflux, of your heartburn, and how worried should you be about those pills you're taking? I hardly need to tell our audience how common heartburn or gastric reflux is. It would seem to me there wouldn't be any sitcoms on television if it wasn't for the advertising dollars generated by people advertising products to deal with heartburn. The drugs which are used are among the most commonly recommended, and when they're prescribed drugs in the country. But recently there have been concerns raised about an alleged association of one class of treatment for gastric reflux disease with dementia. And so I thought we should have a chat about that today. And we have two panelists to discuss it with us. So I'm going to ask our panelists to introduce themselves, and let's go in alphabetical order. First, Dr. Etienne.
Hello, thank you for having me, Dr. Halperin. I'm Dr. Etienne, Vice Chancellor for Diversity and Inclusion here at New York Medical College, Associate Dean of Student Affairs, and I am an Associate Professor of Neurology and Medicine, subspecializing in epilepsy and brain injury medicine.
Welcome, Dr. Etienne, and Dr. Lebovics.
Thank you very much for having me also, Dr. Halperin, and my name is Edward Lebovics. I'm the Chief of Gastroenterology and Professor of Medicine at New York Medical College and at Westchester Medical Center.
Gentlemen, welcome. Let's start with the basics, Dr. Lebovics. People use the term GERD, gastric reflux disease, heartburn. What is it? What are the common symptoms? How commonly are people prescribing or recommending drugs for it?
So GERD it stands for gastroesophageal reflux disease, and in its classic form, it refers to the symptom of heartburn and regurgitation that occurs 2 or more times weekly. It's certainly common for people to have heartburn after a large fatty meal from time to time. The drugs that are used for this condition are now widely available over the counter, so it's hard to really say how commonly they are used, but in one survey, as many as 60% of outpatients were taking acid reflux medications. It's considered safe and a first-line approach to take 8 weeks of therapy for someone who's suffering from heartburn. But the long-term use of heartburn medication really should require evaluation and confirmation that, in fact, the symptoms are related to reflux. That may include endoscopy, it may include a pH study, but we can get into that if that's relevant to the discussion.
Well, thank you. Dr. Etienne, there's a rising incidence of dementia in the United States. It's an enormous burden for families to care for a loved one. I'd like you to teach our audience a little bit about what we think about the pathophysiology of this disease, because the whole story of the proton inhibitor drugs for reflux has to do with allegations that it causes buildup of certain proteins in the brain. So maybe you can explain this alleged mechanism to our audience, and then we'll dig into whether this association is real.
Yes, thank you for that question, Dr. Halperin. So as many of you may know, dementia is a condition where people have a progressive decline in their cognitive function, meaning they have increased problems with thinking. And there's many forms. You've probably seen it on the news. Some people have difficulty speaking. Some people have trouble with their memory, trouble with spatial orientation, finding directions, finding their way. The type that tends to get the most press and that people think about when they think of dementia is typically Alzheimer's disease, which, as you alluded to, is a buildup of certain proteins in the brain that we believe contribute to that gradual decline in function. And there's been preclinical studies that have suggested that these proton pump inhibitors might increase those levels of those proteins, which we have not seen that bear out in practice.
Yeah, there's certainly been an awful lot of energy invested in this mechanism of action, and among the disappointments is that no drugs supposedly targeting this mechanism seem to make a difference, do they?
Well, that was the case until this year, when the FDA did approve a new medication called lecanemab, which does target tries to block the production of that protein. And what we've seen, at least what the clinical trials have shown for that particular drug, is that it has been slowing the decline in cognition in people with dementia.
Yeah. Very important. Thank you. Okay, well, let's dig into the question before us, Dr. Lebovics. In preparation for this panel discussion, I did some cruising of that well-known, reliable source of medical information, the internet, and it's certainly not hard to find lots of postings alleging there's an association between proton pump inhibitors like omeprazole, drug which you can easily get a hold of without a prescription, and alleged onset of dementia. What do you make of it?
So I think your choice of words, association, is a very telling one. And I think it's critical, not only for this question, but for many medical questions, that we understand that association does not imply causation. A and B can be associated, doesn't mean A caused B. There are criteria for causation. The most important criteria for causation is the strength of the association, along with other things such as temporality, that, you know, A happened before B, etc. The strength of the association between exposure to proton pump inhibitors, such as omeprazole, and dementia is, number one, very weak, within the range that would be very suspicious for statistical bias. I actually looked it up. It's 1.34, a relative risk of 1.34. Let me just explain what that means, because sometimes in the lay literature, that is interpreted as saying the risk of dementia in people who use these drugs is 34%. Couldn't be farther from the truth. If you have a stadium, say a Yankee Stadium, full of people, and there's a disease that will occur in one of them, but if they're exposed to a certain drug, it will occur in two of them, well, that's a relative risk of 2. So it's 2 out of 60,000 instead of 1 out of 60,000, which is really not statistically important. Bottom line, the bulk of the literature with dementia and proton pump inhibitor use shows no association, and the often quoted study showed a very weak association that did not meet the criteria for causation. So I think it's really not a concern at all. Having said that, obviously no drug should be used if not for an appropriate indication, and the same applies to PPIs.
Yeah, and I'll just add, you know, just to combine what Dr. Lebovics and what Dr. Halperin has alluded to is, you know, Dr. Halperin, you said, you know, you look on the internet, you see lots of mention of this association, and because of that, because this idea caught on, and people were reading about it and getting concerned, contacting their doctors, numerous meta-analyses have been completed, meaning people have looked up all the studies available to try to see, is there a signal there that we should really be warning people about, and not just downplay it. And really what all those multiple meta-analyses have shown is what Dr. Lebovics has just said, which is that there is no evidence of a causation of dementia from taking those proton pump inhibitors.
Okay, let's gentlemen assume that the patient sitting in your office listens clearly to what you just said and says, well, I'm not sure the rules apply to me because I have an extremely strong family history of dementia in the family, and parents, and I've got an older sibling who's already in memory care. So do I have to treat this data differently because of a strong family history, or is it still okay if I take it for my reflux? Let's start with Dr. Etienne first and then Dr. Lebovics.
Yeah, so what I usually do in that type of situation is I always remind patients, and I say it in more, common terms, we always, for any medication, we want to look at the risks and the benefits. What is the downside? What bad things might happen? But what's the positive of you taking that medication? And if it's clearly needed, where you do have this reflux problem or problems with ulcers, et cetera, then absolutely, I would say you should take it because you have an actual problem that you're treating. But I would not recommend taking it willy-nilly to say, oh, I just feel like taking it just to take it, because then there are other risks associated with these medications besides this idea that's already been demonstrated to not be true. But there are other risks of medications that you should be concerned about.
Thank you. And so, Dr. Lebovics, how would you address the concerned patient sitting in the exam room who wants to tell you about their strong family history of dementia?
Well, I would tell them that they should address their strong family history of dementia with Dr. Etienne. And I would reassure them that it has nothing to do with their use of a proton pump inhibitor. Although I would review with them whether they in fact need to take a proton pump inhibitor, regardless of their risk of dementia. These drugs are frequently used without an indication. They're frequently used, a patient will ask me for a refill and I'll say, why are you on it? And they'll say, I don't know, I've been on it for 10 years. I don't remember why I'm on it. Well, maybe they don't need to be on it. The indications for long-term use of a proton pump inhibitor, specifically for gastroesophageal reflux, are for patients who have severe erosive esophagitis by endoscopy, or have proven reflux that is refractory to other options. And then we will get them on the lowest effective dose of acid suppression that keeps their symptoms in check. So yeah, many patients are on these drugs unnecessarily, and that needs to be addressed, but it has nothing to do with dementia.
Okay, so let's wrap up with a question I'm going to predict on the minds of lots of our audience, because I've been sitting in this chair now for a couple of years. Someone's, I'm sure right now, typing in the question box, you people are always talking about pills. Why hasn't anybody talked about non-medical, non-pill management of GERD? So Dr. Lebovics, let's talk about that. What can people do besides going on Amazon and ordering themselves a 3-pack of proton pump inhibitors?
Well, that question is quite to the point. Patients who suffer from symptoms of reflux need to adhere to some lifestyle modification, such as avoiding fatty foods, chocolate, caffeine, alcohol, smoking, mints. They shouldn't eat within 3 hours of bedtime when they're going to recline. They should sleep on their left side or elevate the head of their bed. If they're overweight, they should lose weight. Frequently, that will solve the problem. The patients who we treat with medication are, a small slice of the large pie of patients who have heartburn.
Thank you. Dr. Etienne, let's finish up with you. Patient says, well, okay, I'm going to have POP continue to take the proton pump inhibitor, but doc, he's just not right. He keeps misplacing the car keys. He can't remember the grandchildren's names sometimes. Can you give us a brief introduction to what actually happens if you bring grandpa or pop to the neurologist and says, is this dementia or is he just normal variant?
Yeah.
Or he's just getting old and he needs to remember where his car keys are.
Yeah, no, excellent question. The truth is that, memory loss is something that lots of us will have. Some of us have it, when we're younger. I misplace my keys every now and then. But to actually move from calling something, normal aging or normal memory loss to dementia or a mild cognitive impairment is that the person is going to have an impairment of function. There's something that you could do before that you could no longer do because of this decline in brain function. And that's typically what I look for during the evaluation. Also do very rigorous testing of the memory, spatial orientation to look for subtleties. And one of the big challenges that that's very tricky is people who are highly educated. Because somebody who's got, advanced degrees, masters, PhDs, MDs, law degrees, have such high level of functioning. So I actually have to kind of evaluate them differently to some degree because of the fact that they might be performing excellent on the cognitive testing, but they're still below what they were at their kind of like when they were really highly functioning. For example, word generation. We expect them to say a certain number of words in a minute. Somebody who practiced law or worked as a 911 operator or where they used to talk a lot, if they're getting only 13, 14 words in a minute, even though that's considered normal, for that person, it's not normal because they should be able to generate 50, 60 words because of that. So we do very careful testing to see where you're at. And then just to put the plug, I'm glad you asked Dr. Lebovics about diet and exercise. I agree 100%. This is one of the biggest things that we do for people who are at risk for dementia is focus on, healthy diet, doing some level of physical activity, whether it's walking or if you're not able to walk, you could sit down and do some cycling. Having movement is very, very important for preventing that cognitive decline.
I want to thank Dr. Etienne and Dr. Lebovics. I hope for those of you counting that all three of us use the right number of words per minute. And we'll be seeing you again during the question and answer portion of our webinar. Thank you, gentlemen.
Thank you, Dr. Halperin.
Thank you.
Hello again, this is your host, Dr. Edward Halperin, hoping some of you will consider giving back to New York Medical College. Programs like you're watching today and our virology research programs take time, effort, and money. We hope you'll consider a tax-deductible gift to help offset our costs. Great things are happening here at New York Medical College. We hope you'll be a part of it. If you'd like to make a gift by phone, dial 914-594-2720. And like we say, operators are standing by to take your credit card information for a charitable donation for our COVID-19 education and research programs, or go online to www.nymc.edu/give to do it all hands-free on the computer without having to talk to a person. And for those of you who believe in ink and pens, we'd be more than happy to receive your check made out to New York Medical College. Put in the memo line on your check, COVID-19 webinar support, and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us during these challenging times. Stay safe and healthy. Please consider writing a question for one of our panelists in the Q&A box as the program continues, and we'll get to as many as possible. And now let's get back to our program.
Hi, I'm Dr. Lori Solomon, Chair of Family and Community Medicine at New York Medical College, and I'm very happy to be speaking to you about something other than COVID today. I will be talking about family history. What do we actually do with the information from family history, and what kind of records should a family retain about their medical history? I have no conflicts of interest to disclose, so let's get on with the topic. What is the purpose of family history? Well, there's actually multiple purposes for the family history. One is the identification of genetic syndromes or genetic problems that run within a family. So taking a family history will allow us to determine whether there's a risk for a genetic syndrome. It's also a way that doctors can evaluate our patients' individual risk for developing certain diseases like cancer, heart disease, diabetes, substance abuse. And lastly, through a family history, it provides us a context for caring for our patients holistically in a patient-centered way. For example, a family history may uncover stressors for the family or for a patient, such as the illness or death of a loved one, the presence or absence of a support system, the presence of family trauma. So this is perhaps traumas related to diagnoses that have happened throughout the family, perhaps even context of medical care within families and the significance of diseases in families. For example, distrust of the medical system because of perceived poor care or misdiagnoses in the past. And it also provides context for mental health issues in our patients. A family history can also point us to the need for additional testing done at a physical. So perhaps if we've uncovered a possible genetic syndrome or the risk of a genetic syndrome, we may refer our patients for genetic counseling or genetic testing. The presence of cancers that run in the family may actually change our screening for individual cancers, such as starting breast cancer screening at an earlier age or colonoscopy at an earlier age, or perhaps either being more thorough on a skin examination or advising our patients to have annual skin exams with the dermatologist, say, for example, if they have a family history of melanoma. Additionally, we may order testing that we wouldn't normally order for patients based on family history. So, for example, a family history of diabetes would prompt us to screen our patients for diabetes. Even though tuberculosis is not a disease that is passed down through genetics, it is something that is transmitted through close personal contact. So a family history of somebody with tuberculosis would prompt us to test family members for tuberculosis. Additionally, family history can help us in counseling our patients on lifestyle decisions. So sometimes family history of a particular disease will function as a reason to adopt a healthier lifestyle. So, for example, if somebody has a history of heart disease in the family, that may be a good driver for helping them quit smoking, so that they can reduce their risk for heart disease in the future. For people who have a history of high blood pressure or diabetes in the family, they may need to focus on physical activity or improving their diet to prevent the onset of disease. And that's much more important than actually, so we can make a change before the disease develops. And then those with a family history of, say, substance abuse or anxiety or depression may benefit from counseling on stress reduction techniques or doing some individual therapy. Last but not least, family planning is an important topic. So if there's a history of genetic syndromes, perhaps that needs to be elucidated, and that may impact people's decisions about how they start a family. So what can you do as a patient? Well, the most important thing is to be curious and talk with your family. So when you get together with your family, move beyond the pleasantries of hi, how are you doing? But really get a sense of what medical problems they have and what they're struggling with. Ask your parents about the health of their siblings and their parents. And parents, it's your job to relay your family history onto your children. At the age of 18, they're adults and they should be able to provide their own family history. So please educate them and continue to update them on your own health conditions. You're not burdening them. It's a very important part of their medical history. So when you're getting ready to see your doctor, here are a few things that you can think about before you go to your visit. Are there diseases that are present in multiple generations in your family? Are there genetic syndromes? Has anyone done any previous genetic testing? If they have, if there's people in your family who've done genetic testing, what are the results? Can you find out before you go to see the doctor? Are there diagnoses that run in the family of breast cancer, colon cancer, prostate, melanoma, lung cancer, endocrine cancers like pancreas or thyroid cancers? Is there a history of diabetes or high cholesterol or high blood pressure? Those are important to bring up at your doctor's visit. And although it's not talked about very much in families, a history of alcoholism and mental health diagnoses are also important. Think about, is there anyone in your family who had a heart attack or stroke before the age of 50? That's an important thing to tell your doctor about. Additionally, any history of sudden deaths or deaths at an early age or miscarriages can be important. So if you can find out that information, that's important. And lastly, are there any infectious diseases that have been that are running in the family, such as tuberculosis? Important to let the doctor know. And lastly, the question of what records should you keep? I'm here to let you know that it is okay to not keep tomes and tomes of medical charts from your parents. The most important thing really is at the very beginning of the medical chart in a place called a problem list. That will have a list of all of your parents' diagnoses. And that's the important thing. So find out what diagnoses they have, write them down, go through the chart and see if there's any genetic testing that was done, any reports from genetic counselors. Those things should be retained. And that's all that you need. You should, for your own personal benefit and for your children's benefit, keep a list of your family history, whether that's on paper or an electronic version, and make sure that you update it when new problems arise, both in your own family and in your extended family. Thank you very much for your attention and have a great summer.
Hello again, this is your host, Dr. Edward Halperin, to give you instructions as to how to get your CME credit for those of you who want your continuing medical education credit. You have to record your attendance, so you either whip out your cell phone and send a text message to 828-295-1144 and type the code 64VOID, all in capitals. Type that into the message, hit send, and you'll get instructions back as to how to fill out your quality assurance questionnaire for your satisfaction with today's program and how to download your certificate for your CME credit. Your other choice is to use your computer, laptop, or your cell phone and scan the QR code, that sort of checkerboard looking device in the right-hand corner. You scan that and it will automatically take you to the website where you can go ahead and fill out the satisfaction questionnaire and get your CME credit. However you decide to do it, go ahead and do it, because the code's going to expire on Thursday, July 6th at 12:30. It'll stop working after that point. So may I suggest get out a pencil and paper and write this information down, or you take a screenshot, or you take a photograph of your screen with your cell phone. Go ahead and do it so you can be sure to get your CME credit. Now, as I always say, if you want to ask a question of any of our panelists, go ahead and type your question in the question and answer box on your computer screen, and we'll get to as many of them as possible during the question and answer portion of our program. And let's continue with our program.
I'm Dr. Alan Kadish, the president of New York Medical College and Touro University, and I'll moderate the question and answer session from today's very interesting presentations. Dr. Solomon actually is unfortunately not with us for the Q&A session, so the questions will be addressed to the other four presenters. We'll start with Dr. Lebovics. You and Dr. Halperin, as well as Dr. Etienne, mentioned a number of generic names for drugs. One of our listeners was curious as to what are the more commonly used trade names so that they can understand what drugs you're talking about.
So the proton pump inhibitors on the market, the trade names are Prilosec, Protonix, Nexium, Acifex, Prevacid. I think I got them all.
Okay, and certainly the most commonly used ones are Nexium.
Nexium is a very common one, for sure.
Great. Okay, another question, Dr. Lebovics. So does the use of proton pump inhibitors change the GI system pH, and are there inherent risks or side effects associated with that?
So yes, the goal of using a proton pump inhibitor is to suppress acid secretion, which it does very potently. It does not completely eliminate acid secretion over a 24-hour period, unless it's used at higher doses. And there are potential concerns about that. One of the side effects that is studied regarding the long-term use of proton pump inhibitors is an increased risk of enteric infections in the GI tract, including Clostridia difficile infection, other bacterial infections, because acid is one of the protective mechanisms that we have to keep that from happening. But again, I would stress that coming up with a mechanism generates a hypothesis. It doesn't prove that this in fact happens. And again, the data is equivocal on whether there's an increased risk of infections. Long-term use can result in B12 deficiency because you need acid to absorb B12. But again, we're talking about patients who are using these drugs regularly for years, not weeks, not months. There are other other potential concerns, but these are things that, again, we look into in patients who require the use of a proton pump inhibitor and use it over the course of many years. Thanks.
So another listener had a follow-up to the first question, which is, of the different proton pump inhibitors that you described, do you think one's more effective than another? Is one safer than another? Which one do you prescribe if you're prescribing a proton pump inhibitor?
They are generally considered interchangeable. There are patients who will respond to one better than another. As is often the case in medicine, it's not our decision, it's the insurance company's decision, but I don't think there's significant difference between the different proton pump inhibitors.
So would you recommend the cheapest one, particularly if it's available over the counter? Is that what you would
Absolutely, that is a perfectly reasonable choice.
Great. One more question for you, and then we'll move on to some of the other panelists. You talked a little bit about elevating the head of the bed. So how do you suggest doing that, and how high does the elevation have to be? Is it an angled pillow? Is it a mechanical bed? Is it changing the position which you lie in? What's the most effective way to do that? And how high do you have to be?
So a great question. I think the most effective way to do it really is the simplest, which is to sleep on the left side. That makes all the fluid in the stomach fall. If you look at a picture of the stomach, it falls to the greater curvature of the stomach away from the junction between the esophagus and the stomach, and is pretty effective. Many people will tell you they roll over and they go on their right side and they'll get woken up by reflux. People who, for whatever reason, can't sleep on their left side, they have shoulder pain, people who turn around a lot during their sleep. So then elevating the head of the bed to 45 degrees. But again, here I would emphasize, it's not just putting pillows under your head, it's the whole upper body that has to be elevated. So that would be done with a wedge. There are many of them on the market. 45-degree wedge is what's recommended. And that has its own issues of people rolling off and slipping down. Nowadays, lots of people have these fancy beds that allow them to elevate their upper body. So those are the best ways to do it.
So 45 degrees seems like a huge elevation. Is that really sustainable for most people in terms of the way you sleep? Or do you just kind of roll down if it's that high?
Well, I tell people, do the best you can.
Great.
You can't do 45, 30 degrees is, I guess, the next best thing.
Great. Thank you, Dr. Lebovics. The next question is for Dr. Etienne. Dr. Etienne, you mentioned lecanemab as a new drug that's been approved for dementia. How strong is the evidence, and are you using that routinely? And how do you screen people to decide who should take the drug and who shouldn't, if you're indeed using it clinically?
Yeah, thanks for that excellent question. So lecanemab just got FDA approved this year. It's an anti-amyloid antibody medication that is taken basically once every 2 weeks IV infusion. In order to be a candidate for lecanemab, based on what the clinical trial results are, one is you should have mild dementia or mild cognitive impairment or any form of mild dementia. They do need confirmation of amyloid pathology, which right now we do it by doing an amyloid PET scan, which is a special kind of scan of the brain to look to see if you have evidence of amyloid. The evidence is, I'd say it's pretty strong, very good evidence that showed it slowed the rate of cognitive decline by 27% over an 18-month period. So based on those results, it does seem like a strong evidence. And the other thing I'll add is that 25% of the subjects in the pivotal clinical trial on lecanemab were Black or Hispanic. So they had a very diverse recruitment, which tells us this is a drug that was tested broadly in the population.
Great. Thank you very much, Dr. Etienne. I appreciate that answer. So the next set of questions will be for Dr. Srinivasan. Thank you for a great presentation. And it's great to see you on video.
Thank you, Dr. Kadish.
So the first question is, you mentioned in your slides that working the night shift increases your risk of breast cancer. That sounds almost like something mythological. Can you tell us a little bit more about that? How great is the risk increase, and what might be the etiology? What's the cause?
So there are some factors which are the risk factors of breast cancer that have been listed by American Cancer Society and other cancer societies as risk factors that you can and cannot change, but also those that we don't have a direct causation or a pathway to prove, but we found it as an incidence to be higher. Now, it's very difficult to tease out each and every one of them away from the other. So some of the ones that fall in the bucket of, we know that there's a higher incidence, but we don't know why, but they may all be related. One of them is night shift work. But another one that's a higher association is lack of physical activity. Now, it makes you think the two could be connected because you're, usually in a sedentary night shift job, you might be at a higher risk, you might be sleeping during the day. And similarly, we know that smokers do badly. And, we don't know if the night shift forces you to be a smoker, stay awake. But there is some alternation in melatonin, and there is a lot of research going on if this is somehow related through a pathway to a higher incidence of cancer. Because there are so many other confounders, it's difficult to pinpoint exactly the risk.
Thank you. So the next question relates to a family history of breast cancer at a quote younger age. So two interrelated questions. One is, at what age is the increased risk of breast cancer in a relative significant? And how much does that increase one's risk?
So these are quite well studied, especially with respect to the BRCA1 and 2 testing. So as a practitioner, I have to establish, using NCCN guidelines, what the individual risk for the patient presenting to me is, in order for me to actually say that this patient requires genetic testing. As part of that, I will have to ask the patient how many close blood relatives they have who've been diagnosed with breast, ovarian, and other cancers. And that also depends if my patient themselves have breast cancer and at what age they've been diagnosed. For example, if a patient's cancer has been diagnosed at age 40 or younger, I don't have to go further in too much detail about their cancer history in the family. They will qualify for genetic testing. If they have what's called a triple negative cancer, which means they don't have estrogen, progesterone, and HER2 receptors, and they're under the age of 60, again, they'll qualify for a full genetic testing. And we would like to know, despite their relatives or family history in those cases. In those that are 50 and younger, if they have 2 or more close blood relatives, we generally ask them the age. The younger the blood relative has been diagnosed, to their memory, most of them will not remember at what age the relative was diagnosed or treated or passed with the cancer. But if they will remember, most of them, if somebody has a sister that died at 40 from a breast cancer, now that makes it significant when I'm dealing with the patient, and that patient automatically will qualify for genetic testing. And these can all be found very clearly in the NCCN guidelines. Any patient with a male breast cancer relative will also qualify. Any patient with the Ashkenazi Jewish descendancy will also qualify. So there are very specific criteria that will allow me to send the patient for genetic counseling and testing. But in general, the younger your relative is at the age that they've been diagnosed with cancer, it immediately prompts me to think that there may be something genetic there.
So if we're talking about screening rather than looking at someone who's already been diagnosed with breast cancer, in someone with a substantial family history, how early would you begin screening?
In general, for these criteria, 50 and younger at the age of diagnosis, of the relative is considered having a relative with a young age breast cancer. And if you had a close relative who was diagnosed at that age, our general recommendation is we should start screening you 10 years earlier than the index person in your family.
Great. Okay. The next question, the next two questions actually both relate to imaging. So the first question is, are there different techniques you would use for screening in someone with dense breasts?
That's an excellent question. By federal law, we are supposed to report dense breasts in every mammogram report. If there is dense breast, it decreases the sensitivity to pick up any hidden cancers, and the reading accuracy goes down. However, this has been improved with newer improvements in the actual imaging, like tomosynthesis, which deals with the dense breasts a little better. Also, dense breasts generally should be supplemented with a focused sonogram. At the same time that you have the mammogram, if they find that the report has a dense breast and they're concerned about it, they will call you back, or at the same time complete the imaging with a diagnostic sonogram and then give you the BI-RAD reading. Assuming that these, generally between this, we are able to arrive at a BI-RAD reading. If it's still not possible, then in those cases, we will consider alternate imaging like an MRI if the patient is still high risk for a cancer.
Thank you. What causes dense breasts? What does it mean? I realize it means that it looks different on mammography, but what's the underlying physiology?
It's actually considered a normal physiology. So a breast start atrophic, then they have lobular proliferation, ductal proliferation, and then the maximum activity in the breast is during pregnancy or reproductive cycle. And then as the age approaches menopause, our glandular tissue all moves towards the central area and a little bit towards the upper outer quadrant. And the rest of the breast pretty much gets replaced by very clear fatty tissue. So an excellent mammogram to read is usually a postmenopausal woman with clear fat, where you can see the gland tissue in one area. And if there's an abnormality there, you can immediately pick it up. Now, the opposite is somebody who's lactating, somebody who's still actively menstruating and has lobular breasts. Those patients tend to have what's called dense breasts on mammograms.
Thank you. Then the last question, you alluded to the use of MRI in people whom you can't get adequate images otherwise. In your view, is that the use of MRI at this point?
Yes, it is not a primary screening modality because just like in any other field, a screening test should be universally available, should be standardized reading, and the quality should be assured. And we need to have multi-year or decades of data to say that this is good enough to be a screening modality. So MRI is not a screening modality for general populations because of that reason. Also, the technology is rapidly evolving in MRI. When we started using MRIs, there was a lot of false positives, meaning it would pick up anything and everything, and then our biopsy rates will go up. And also, it was notorious for not picking up good in situ cancers, which is what we want to do when we have screening modalities. We want to pick up the cancer early. So it wasn't quite helpful as a screening modality, but as an adjunct or a secondary modality, it is useful in patients where we want to screen younger patients because of their strong family history, or we want to make sure that the extent of disease is well described before we undertake an extensive surgical solution.
Thank you. So appreciate it so far for today. That's the end of the questions for you, Dr. Srinivasan. Thanks again for your participation.
Thank you very much.
So Dr. Trepal, we have the last set of questions for you. No comments on the area of the body that they're associated with. That's simply the way the questions came in. One of the TV commercials for antifungal agents showed an actor talking about passing on the fungal disease, the foot fungal disease, to others. Is it infectious? Is that something we need to worry about?
It can be. It's not in the mannerism that you would catch the flu or a more contagious bacterial disease, but a dermatophyte loves a warm, dark, moist environment. So a foot in a shoe is a Garden of Eden for a dermatophyte to flourish. So if you're passing it along through wet bathroom floors, on carpets, it usually needs to get entry into it. And dry, chafing skin is a good way. And usually it's the skin infection that comes first, and it kind of migrates its way into the toenails after the fact. But yes, I mean, you can pass it along. It's not that easy to do so, but good foot hygiene is an important part of dealing with this. I tend to tell patients who have chronic tinea that when they do their laundry, to make sure they wash their socks in temperature water at least 150 degrees, or to use a Lysol detergent, because spores can survive a normal wash on that. So you can reinfect yourself. There's recurrence rates, and it can be passed on to others.
So you talked about how the therapeutic response rates are not fantastic, and that for topical therapy, the course is many weeks. For oral therapy, it's 12 weeks. So I have two interrelated questions. One is, why is the therapy need to be administered for such a long period of time? And how quickly during the course of therapy will patients see improvement?
That's a great question. And it depends on where your starting point is. If it's mild disease that's not involving the lunula, it's just some distal subungual onychomycosis, you're going to get a better response to it because you're starting at a better spot. For someone who has a centimeter thick toenail that is brittle and flaking, the problem is that the dermatophyte lives under the nail plate, and anything you apply either topically or even taken orally, there is a significant lag period of time. With the topicals, that it has to penetrate the nail plate to get down to where the fungus is residing. And on the orals, it has to get gradually laid down in the nail bed. The orals it's a lipophilic substance, so it'll go into the membranes of the nail bed. And with the orals, again, it's about a 3-month, 90-day. With the topicals, if you start out with mild disease, you can see some clinical improvement in 6, 8, 10 weeks, although generally it is 10 months of once-a-day application to it. And if you're starting with a really thick, dystrophic, brittle toenail, the chances of getting a normal toenail out of that is very slim. But they're excellent question.
One of our listeners wanted to challenge you a bit on Vicks VapoRub. Apparently, Vicks VapoRub contains thymol, and thymol has antifungal activity. So where does thymol fit in? And does Vicks VapoRub have enough of it for it to really make a difference and potentially be effective?
Well, absolutely. Again, another great question. Absolutely true. Thymol is it has antifungal properties, and if you were using it in the Petri dish, that would be fine. The problem, as I said, is that thymol needs to get through the nail plate underneath it, and the other vehicles in the Vicks vapor rub doesn't permit the penetration of the thymol to the active area where it needs it. And that's the problem with the topicals. The prescription ones have a vehicle in it that will penetrate the thick keratin of the nail plate and allow the active antifungal agent to get to where the fungus is. So it's not a question just of the antifungal agent. It is getting it to where the fungus resides and needs to be treated. Again, another great question.
Thank you very much, Dr. Trepal. I appreciate that. So we actually have one more question that's come in for Dr. Lebovics. And if he's still with us.
Here I am.
Thank you, Dr. Lebovics. So there's a question about the effect, there's been a lot of work lately about the microbiome and its impact on gut and overall health. So can you tell us a little bit about that, and then also answer the specific question, which is, do PPIs affect the microbiome?
Well, that is a great question. I think the information at this point is somewhat tentative. Just for those who need a little introduction, there are more bacteria living in your GI tract. There are more bacterial cells living in your GI tract than the rest of your body combined. So there's more bacteria sitting in your chair right now than the rest of you. And the makeup of this microbiome is now being studied in many areas and has an enormous impact clearly on medical issues ranging from obesity to cancer risk, and the list goes on and on. And no doubt the acid environment of the stomach plays some role in that, but I don't think we know at this time whether it is something that is of clinical import.
Got it.
That's the best I could do.
So you wouldn't be concerned at this point about taking PPIs because of the effects on the microbiome, simply because we just don't know enough is really what you're suggesting?
Well, I think this goes to the point that I tried to make, which is that PPIs, just like any other medication, should be taken for the least at the least effective dose for the least required duration, and for legitimate indications. Is it possible we'll find out that there's some adverse sequela from taking PPIs? Sure, but we know that there are adverse sequela in people who have severe erosive esophagitis, Barrett's esophagus, who need to be on non-steroidals and have had previous GI bleeding. Those people need to take their PPIs, and they have real health risks if they stop. But people who don't need to be on them should not take them.
Great. All right, that's very clear, and thank you. All right, look, this has been a great panel. I want to thank all of the panelists, both those who are here and those who are not, as well as the audience for a fantastic set of questions. And once again, it's been great being with all of you and trying to address some of the complex medication issues and health care issues of the day. And I want to add my thanks to Dr. Halperin for once again putting this program together. Have a great summer, everybody. And we look forward to seeing you in the fall at our next session. Have a good day.